Thank you very much, Lena. Thank you for the introduction and for looking after the webinar. I'm Ali Kubba, and I'm really delighted to be talking to you on the platform of the European Menopause Society, Menopause and Andropause Society. EMAS and the European Society of Contraception are sister societies, and we would like very much to work together and share our common interests in women's health. So this is my front slide, and you can see that I have Big Ben in the slide. That is because St. Thomas's Hospital, well, there are two hospitals that I work in. St. Thomas Hospital is just across the bridge. This is the Westminster Bridge. These are the Houses of Parliament. So St. Thomas's is just at the end of this bridge, which is one of the hospitals I work in. I also work near London Bridge in the London Bridge Hospital, and I'm the Vice President of the European Society of Contraception. So delighted to be with you. And just to also mention, I've got King's College London. Guys in St. Thomas's is part of King's College London, and I'm on the academic staff. I have a declaration of interest, as you can see, but I use the slide to do two other things. The first is to salute the healthcare heroes that have looked after us and after the population and worked so hard in the past year and will continue to do so. So we really stand in awe and in respect for all the healthcare workers, everybody from the security people in the hospital, to the people who produce the food, to the people who look after the patients. The agenda for today's meeting is fairly varied. I'm going to just look at why we think women do better with COVID, and these will be fairly simple slides, they're common sense. I'm going to look at services for women now in the future, just look at the trends that had already started actually before COVID came into the scene and are likely to be much more in use from now on, especially the use of virtual consultations and telehealth. Obviously, contraception is part of sex, sex is part of life, so I'm going to show a couple of slides at the end of the talk probably about what I call love in the time of COVID. These will be light-hearted, hopefully. But the main section of the talk will be on contraception. And I'm going to review the methods, in a way, give you also some information about the methods of contraception as an update, and look at how we are adapting these methods to the era of COVID. And obviously, conception doesn't stand on its own. It's part of reproductive health, which is part of gynecology. And therefore, I'm going to mention the rest of what I call the package. The package would be, what about women's screening services? What about general gynecological issues? What about menopause, which obviously you know much more about, and therefore I'm not going to touch that much about it. What about talking therapies? Because we are in a situation where COVID itself is causing a lot of mental health morbidities, but actually being isolated, women taking responsibilities for the family are also causing a lot of stress in the environment of the family. And therefore, having someone to talk to, I think, is very important. And I'm going to also highlight the fact that emergencies, be it gynecological or otherwise, are very important to for services to be maintained in producing emergency care. I'm not going to talk about training because it's outside the scope of this talk, but training has also suffered at the time of COVID, and we have challenges in training the medical students and in training the junior doctors. But I hope we will be able to overcome these challenges with technology. So the pandemic has given us a new focus on a number of things. I think it highlighted the issues around relationships, be it with couples who have been close having to be far apart, or be it couples that have been part of a unit being together locked down and therefore maybe looking at tensions and issues within relationships. I think it also brought into focus healthy sexuality, the fact that sex is an essential part of our lives, and therefore healthy sex, happy sex is actually very important. And we as providers of care to women and to couples need to really help them to overcome the challenges of isolation and loneliness and difficulty in communications during the pandemic. It also highlighted the gender dynamic. And I think this is very important. As you know, the WHO essentially feels that, or has reported that the intimate partner violence has really increased during this year of the pandemic, and we need to be aware of that. And I put a little neighborhood which seems to have the gender dynamic really wrong. So apologies if this sounds too flippant, but it is a serious point. I think us, the population, us people like me and you who are coping with the challenges during the COVID era, have learned that we should not take our health for granted and have to look after the physical as well as the mental aspects of our health. I think if you're dealing with contraception, and because of issues around the access to contraception, issues about access to information, and sometimes the challenges in talking to women who are seeking contraception, highlighted the fact that actually in a society where pregnancies are ideally should be planned, being contracepted is the preferred state in uncertain times. You know, it could be that in the challenges of this time, pregnancy, especially implant pregnancy, would be really an adverse event. And therefore, being contracepted is the preferred state in uncertain times. And a couple who then need to switch off their contraception and try for a baby will be most welcome to do that. But the point is to try to avoid unplanned pregnancies. And I think more and more women that I see in my clinic have been looking after in the past year are starting to learn to self-manage both their physical and mental health, and are finding ways of keeping well, keeping healthy, looking at their diet. Funny enough, though we have a minority who says, you know, I was smoking and I'm smoking a bit more because of the stress. Others have said, actually, I know smoking is bad for your health, but it's bad in COVID times, and therefore they're managing their lifestyle even better. They have time for exercise, but mental health, I underline mental health because I think it's very important for us to be aware of. So let's talk about why do women do better? Well, this is a fun slide. We who deal with women's health say because women are more clever. So you can see this image essentially tells you that men can only focus on one thing at a time, while women multitask and multitask in a big way. And of course, the challenges for women during the COVID era has been really substantial. This is homeschooling, dealing with children who are away from school and have to be taught and have to be kept interested and kept happy. Managing the rest of the family, including the man in the family. And I come, and I'm going to show you probably one other slide from my home country. I come from the Middle East, and this is a slide from my home city, Baghdad in Iraq. And it is a monument for Shahrazad and Shahryar. And of course, in the story about Shahrazad is that she, because the king was aiming to possibly execute her, she devised a very clever way of talking to the king, and therefore managing to stay alive. So women do well because they are clever, and this is a political slide which says where women lead, the virus recedes. These are 3 countries that have done well, and especially New Zealand. Germany has slipped a bit recently, but they are coming back, I think. You know, we wish that a lot of our leaders were women and therefore could manage the pandemic better. But this is the more serious one. Why do women do better with COVID? We know that there is a less infection in women, and though in pregnancy you may get more severe disease, but less severe disease on the whole. We think the reasons could be both behavioral and biological. Behavioral, because women probably are more likely to spend more time at home, and they have less risk-taking behavior, and therefore their exposure to the virus is probably less. They're less impulsive than men, they smoke less, and obesity definitely in certain cultures is pretty dominant in men rather than women. Women are more reserved, fear stigma more than males, and therefore they are likely to actually follow instructions. Here in the UK, we have something called hand, face, space. Hand is washing your hands, face is using a face covering, and space is social distancing. So they're much more likely to follow hand, face, and space, and more likely to wash because they are, you know, they do a lot of the keeping the house clean and tidy. But there are biological drivers as well to probably improve the outcome for women with COVID infections. We know that estrogen enhances epithelial, endothelial, and collagen function. So maybe that has an indirect protective effect. We know that estrogen and progesterone have some anti-inflammatory features. We know that estradiol modulates the ACE2 receptors, which are also the COVID access point. And we think that is one of the important points pointing to a biological explanation for this phenomenon. And also we know that it looks like androgens, baldness, for instance, has been associated with higher risk of COVID. So maybe because women have less androgens than men. And instinctively, they aim to protect the children and the family. But obviously, we have to be aware of individual risk factors. So women who have immune challenges, women who are obese, who are diabetic, who have comorbidities will be still at higher risk. And I use this slide when I teach in the Middle East, in my home country, and I usually do a little sort of quiz to the audience and say, well, there are 3 things that are wrong in this slide, and what are they? And I tend to answer the question very quickly. So you can see the little boy here. He doesn't really need to wear a mask. The mask is not fitting that well and probably slightly stressing him. I also point the fact that there is a disabled member of the family, and people with vulnerabilities really should be shielding, especially if they have a physical problem, cystic fibrosis or something like that. But the other point, and that links to contraception, is that you can see that this is a fairly young family. I would say that the mother is probably around the age of 30, but they have 1, 2, 3, 4, 5, 6 children. And I say one of the things that this family needs to keep well and keep healthy for the future is contraception. So let's look at the impact of the pandemic on women. So the challenges have been access to information and the difficulty with fake news, access to services being therapeutic or being preventative, screening, information, and access to the products. In contraception, it is the contraceptive products. In menopause, it is hormone therapies. And this is a recent survey that was done in the UK, and women were asked, have you experienced any COVID-19 related difficulties in obtaining maternal care? And you can see that that is a pretty significant. 36% actually said that they have experienced difficulty. And I think one of the things that now our college here in the UK is correcting is the fact that partners were not allowed into the labor ward or in obstetric units, and that has been distressing for the women. Looking at abortion or post-abortion care, again, at least initially, I think this is less now, 33% said that they have encountered some difficulty. And obtaining medical advice or management for sexually transmitted diseases, that was the highest challenge. And I think that is because a lot of frontline staff in managing sexually transmitted diseases have been diverted to work on COVID duties, and a lot of centers were closed. The good thing from the contraception point of view is that actually this is the smallest number. 8.9% of women said that they had experienced difficulty in the shortage of contraceptives. And I think I will be explaining the reasons for that when we look at contraception. So what are the solutions to these challenges? How do we empower women? And we need to empower women to seek evidence-based information. And our college and the faculty, every guideline that has been put out, there is also a information document for users, for patients. And in the European Society of Contraception, if you become a member, the membership is only 60 euros a year, so fairly good sort of value. You will have access to our COVID resource area, and the COVID resource area has a lot of information about contraception. I think we need to empower women to understand their bodies and self-manage, as I've said, and I think that is really, really very important. This is a time of anxiety in colposcopy where women, feel very anxious. I think once you put them into the picture, you explain that they have low-grade disease, they are much more relaxed. And assure women that we are open for emergencies and essential care. So anybody with red flag symptoms here, the chief medical officer keeps saying, if you have a problem that you're worried about, contact your hospital. I think it's very important that we also make a statement that if women feel anxious or worried and their mental health is really suffering, we should be open for them as well. We shouldn't only be open for physical morbidities. And the concept of click and collect. So for products, we are using deliveries either through coming to a clinic but not entering into the clinic, but most importantly, from pharmacies. And these seem to have worked quite well, and I'll be talking about them in a minute. So in the management of gynecological patients, we think that at least a quarter of consultations can be managed remotely, and that is good for the safety of staff. It's good for managing capacity because we have less staff to do face-to-face consultations. So if you move a quarter of the patients to phone or video consultation, then you'll have a better staff mix to deal with face-to-face. It could be a choice. A lot of women now, if you say, listen, I can see you next week on a Monday in the afternoon, they say, actually, I don't think you need to see me. I need to talk to you. If we can have a phone consultation, then that will be a good thing. But remember, face-to-face consultations are important. They pick up nonverbal communications, and therefore in sexual and reproductive health, they are actually quite vital in some cases, and we will mention some of these as we go along. So examples for managing gynecological patients. For instance, heavy menstrual bleeding, that can be investigated without coming to the hospital. Take a good history, use visual aids as to the amount of the volume of the bleeding. You can probably, if you need, organize for your patient to have a scan, a pelvic ultrasound, and share the images of the ultrasound online, and any agreement, any management plan for drug treatment can be sent to the patient on a click, collect, or even by post. For contraception, again, I think the assessment, a lot of the assessments for contraception and indeed for hormone therapy could be done through virtually on the phone or through filling assessment forms online, and the supplies could be sent in the same way. And one of the advantages that we've had in contraception, and the reason why we have that smaller figure of difficulty of access, is that in the UK, for instance, the Faculty of Sexual Reproductive Health, in the US, the American College, the WHO, all have agreed that for women using long-acting reversible contraceptives, that is intrauterine devices, intrauterine hormone-releasing systems, or subdermal contraceptive implants, we have extended the life of these methods beyond their license. We know that all of these long-acting reversible contraceptives actually work beyond their license age, and therefore we have essentially made what we call an off-license decision, that a woman can depend on the device she is using for a bit longer, and I will expand on this in a minute. If you are having face-to-face, you need to think about aerosol generating procedures, AGPs, and make sure that you have the PPE available to deal with that. Gynae emergencies remain as managed pre-COVID. Acute abdomen, pelvic infection. Of course, in pelvic infection, women can self-test for gonorrhea and for chlamydia. They can either take a self-taken vaginal swab, or this can be done with a urine sample. Early pregnancy bleeding, important to assess. Persistent postcoital or intermenstrual bleeding. I mean, we run a colposcopy service and we really never shut. We reduced our services a bit to protect the staff at the beginning, but we now are, though we have total lockdown in the UK, we have been carrying clinics technically all weekdays and on weekends to cope with the surge in referrals. And one of the interesting things in colposcopy is obviously you cannot examine the cervix remotely. And therefore, we've noticed that in recent months, there's been an increase of referrals from primary care for what we call clinical indications. And you get a referral which says this patient has intermenstrual bleeding and her cervix looks slightly sort of inflamed. And you say, okay, she should go to gynecology, and general gynecology will deal with intermenstrual bleeding. But our general gynecology colleagues say, well, we're running virtual clinics. It's better for you to see her, see the cervix, and take it from there. So we have been doing more gynecology as part of our colposcopy service. But access to colposcopy, ultrasound, and hysteroscopy should be available for red flag cases. And of course, postmenopausal bleeding could also be initially assessed remotely. It has to be done quickly, and then you can have a follow-up as a face-to-face. Talking about a patient's journey, if she's referred or self-referred, offer a telephone consultation, exclude COVID risks. So we talk about whether she's just come back from abroad, something like that, take a history, explain the management. And if they come to the hospital, ask her to turn up on time, because we don't want too many patients in the outpatients at the same time. Wear a face covering, don't bring companions, and have an evidence of the appointment. So you say, bring your appointment letter, because the security people at the door may not allow people into the hospital if they don't have an appointment. And of course, when they are there, we need to protect our staff, therefore maintain social distancing, protecting our patients as well. We don't allow non-essential companions for the gynae outpatients. We arrange the seating for COVID safety. We have sanitizers. We offer masks. We used to check temperatures. This has now dropped a bit because we picked very few people with a temperature. And we say minimize the stay in the unit. So, for instance, for someone who needs an emergency intrauterine device, we do the assessment by phone or virtually by video. And then we say, listen, we're going to book you at 10 o'clock. You come, we will fit you with the device, and then you rest, and then you'll be out of the unit. So the stay in the unit will be much smaller. And the way they move in the clinic is in a one-way system. For the doctor, obviously, PPE is very important. I'm not going to take too long on this. Eye shields are advisable if there is an aerosol generating procedure, and cleaning after each patient. So this is, for instance, our outpatients at Guy's Hospital, and you can see the spacing, and you can see the one directional travel. So we have like a square area, and the participants essentially, the patients will go this way, and then they'll come the other way. This is our reception, and they will stand 2 meters apart. This is the colposcopy unit in the old days, and you can see now we have blocked the number of chairs. So we can only take 3 patients, 1, 2, and 3 in the clinic. Let's move from that to thinking about women in quarantine. So the advice, you can give some general advice, which is important. One is to watch your weight, make sure that you are not, because you're in the house and you're in quarantine, go to the fridge every 10 minutes, as I do when I'm at home. And important to take time for exercise. We say that if you are anxious or depressed, ask for help. Don't assume that help is not available. And if you are, in a way, stuck with your partner for a long time, this is an opportunity to try to get to know your partner even better, and maybe have a second honeymoon at home. This is a poster in Arabic from the Middle East, which says no violence. Very important to be aware of intimate partner violence. WHO calculates that this has been occurring in about 30, maybe even 40% of cases during the pandemic. So it is very important that when you're advising people, you designate some sort of a numerical or other type of signal, so that you know that if a woman is ringing with her abusive partner with her, sitting next to her, you would be able to get a message. So for instance, if she is ringing an emergency line, such as 111, and the partner is there, she can't say, my partner is going to beat me up. We give them a numerical line. So they ring 111, and then they will put 678. 678 to the person receiving the call. They don't need to talk. They can shut the phone immediately. 678 will indicate that this woman is at risk. Or if you are doing, for instance, a phone or a video consultation, in a phone you say, listen, you agree beforehand that if your patient coughs 3 times, 3 successive coughs, that may mean that she is near her partner who may be abusive. So that really is very important. Now let's talk about contraception in the next section of this talk. Access to contraception is a matter of life and death. Increased access causes fewer maternal deaths. And this is from the Lancet series on maternal health. And you can see these are the estimated reduction in maternal deaths. And this is the contraceptive prevalence. As contraceptive prevalence increases, you get more protection against maternal deaths. So it is a matter of life and death. And therefore, we want to make contraception available to as many people, to everybody. The challenges are many, and therefore what we need to do is to set a standard. So the standards that have been agreed really worldwide is that contraceptive care is a time-critical service and needs to be prioritized. So you may not be able to do a lot of face-to-face consultations, but your family planning services have to be open. Abortion care is an essential service and therefore should be provided with no restriction, and this has been the case. And as a matter of fact, the law in the UK has been changed temporarily, and we think there is a campaign to make this permanent, to allow women to have medical abortions at home, and I'll talk to this in a minute. And emergencies are very important. And we've talked already about the time-critical gynecology cases, such as persistent abnormal bleeding, high-grade cervical disease, and I keep putting this severe anxiety. I wanted to just show you this slide from a organization called SH24, Sexual Health 24. This is part of King's College, where I work, and I was very involved in the beginning of this service. And this is essentially a web-based service for contraception. So it provides emergency contraception, it provides tests for sexually transmitted infections by the post or click and collect, and it also provides both the combined pill and the progestin-only pill. And this shows you what has happened during the pandemic. So this is January 2020 up to June. And you can see, for instance, as far as oral contraception, there's been an increase in sending supplies to women for the combined pill, but there's been a massive increase in the use of the progestin-only pill. And we think the progestin-only pill is the pandemic contraceptive. And we'll talk about this a bit more in a minute. If you look at the morning after pill, i.e. emergency contraception, you can see how this service has been providing emergency contraception, again, sending the tablets to the patients, or they pick them up from pharmacies. And this is 2019 until you get to lockdown. And this is what happened to resort to emergency conception, mainly because partners were apart, and therefore there was the opportunities for having sex, protected or unprotected, were much less. And this is the issue around STIs. Now you may say, okay, there is a significant increase in people asking for STI diagnosis kits. Is that because there are more STIs? Not necessarily. It is because many of the STI, the sexual health clinics, were shut or had restricted access, which we saw in the survey that has been done on this matter. So this tells you that telehealth does really work and is something that we should maintain beyond the pandemic. Let's look at the different contraceptives. So combined hormonal contraception includes the oral contraceptive pill, the transdermal patch, or the intravaginal ring. So let's look at pre-COVID practice with the pill. We had already moved to giving women who are perfectly healthy, we've checked their blood pressure, their BMI is fine, they have no risk factors, we can give them a 12-month supply of the combined pill. And we encourage that to happen. It's in the guidelines from the faculty, from the American College, and from WHO. We, for the first time user, we use an online, and this has happened before, we use an online questionnaire looking at the medical eligibility criteria, the so-called MEC, WHO MEC, the UK MEC, the American MEC. That's a checklist women will take. We think that that is actually probably even better than a face-to-face consultation. And then they can have a virtual consultation once they've done this. We need evidence that they've had their blood pressure checked and their weight and their height. We need their readings. And then you can give them the contraceptive, send it, or they pick it up. you have to continuing support and follow up. And remember, we have so-called quick starting. The rule is any method of contraception can be started anytime, as long as you make sure that the woman has not run a significant risk of pregnancy. So anytime if someone says, I haven't had sex in the past month, anytime if they say, my period started 4 days ago and I haven't had sex since, or I use condoms. So you can quick start a method, and these methods, the oral contraceptive, the patch, the vaginal ring, will become effective in 7 days. What happened in the Ovid era? These are the changes. Blood pressure and BMI, if it's been checked in the past year, you can essentially send 12-month supply of the contraceptive. And for first-time request for oral contraception, you follow the pre-COVID advice. What about the progesterone-only method? So as we said, the progesterone-only pill is the pandemic contraceptive. Why? Because it is perceived as being very safe. It does not need a blood pressure reading because it does not impact on the blood pressure. It's a very good bridging method. So if, for instance, someone needs their intrauterine device changing, but they can't get to a clinic to have a new one, and they're worried about cover, you can put them on the progesterone-only pill until this happens, if it is not possible at the moment. It is very easy through telehealth because the medical eligibility criteria and the contraindications are much, much, much more limited. And one of the developments that have happened in the UK is the UK Medicine Agency, which is equivalent to the European Medicine Agency, is currently consulting. It actually will, the consultation will finish at the beginning of March. It's consulting on making progesterone-only pills over-the-counter, giving them an over-the-counter license so that you can actually get them from pharmacy without a prescription and eventually even get them from the supermarket. The other important progesterone-only method are implants. And for that, you can run a virtual consultations. You can show a video of how an implant is fitted so the patient understands what is going on. And then they come for a short procedural visit, which is what we said. You know, you come, you can fit an implant within about 2 minutes. You come and say, listen, you've got a 5-minute slot. I'm going to fit you the implant, having counseled you and having excluded any contraindication. But one of the important things is that we have extended the license. So a woman who says, I've had this implant for 3 years and it's need changing, you can say, well, let's plan changing your implant, fitting you, giving you a new one, maybe in the next 6 months, but this implant you have will be effective up to 4 years. For injectables, for Depo-Provera, this is an intramuscular injection. It probably needs to be given in a clinic. There have been drive-through services. So you essentially drive to a center in your car, and you don't need to get off the car. You just pull your sleeve, and you can be given an injection in the deltoid. Obviously, you have to get all your information as well. But as you know, with injectables, we have Cyanopress, which is a subcutaneous Depo-Provera, medroxyprogesterone acetate, and this can be given as self-injection, and we have supplied it to women, and you have an instruction sheet, and you have a video that you can show to the woman. So we think progesterone-only methods are good methods to be promoted in these COVID times. What about emergency contraception? Well, it's an essential service. The good thing is that emergency pills are available over the counter. They're available by post, and as you've seen with the slide I've shown you, from online services. If someone needs an emergency IUD, this is a priority intervention, and we have kept our clinics open for that. And as you probably use Mirena, the intrauterine system, more than an IUD because it can be used as the progestogen component of combined hormone therapy. There's been a recent study just published in the New England Journal of Medicine, which suggests that Mirena is an effective emergency contraceptive. So watch this space. It is likely that we will be using Mirena for emergency emergency. What about, again, intrauterine devices, intrauterine systems? So intrauterine device, we need to provide these because they protect women long term, and therefore they would actually be good for future pandemics. We have an essential service for these as per implants. We see them as required. We can use the progestin-only pill as a bridging method. We can run an initial virtual consultation with a procedural visit to follow. And we've had the off-license extension. So branded IUDs, such as the T380A, the license is 10 years. We know all the agencies I've talked to you about say that they can stay and are as effective for up to 12 years. For Mirena, we are saying that it is active up to 6 years, and it is likely that Mirena license will be extended for contraception, not for endometrial protection, will be extended to 6 years. Levocert, which is a product similar to Mirena, already has a license for 6 years. We also say, this is pre-COVID, that an IUD which is inserted in a 40 plus woman can stay to the menopause. An IUS, a Mirena inserted in a woman aged 45, can also stay to the menopause. The extended use rules here do not apply to the non-branded IUDs, for instance, the Nova T380. And they don't apply to the lower dose intrauterine system. So the Gides, Skylina, Skyla is not applicable. One aspect with IUDs is immediate postpartum contraception. And that is very important because that is a drive that is going on at the moment where women on the postpartum ward can have an implant service. So we have a doctor or a nurse who goes and essentially fits implants after counseling, obviously, for these women as they're staying for 6 hours or 12 hours before they go home with the baby. But you can also fit an IUD. You can fit it while the woman is in the labor ward, post-placental insertion of the IUD, IUS at cesarean section or vaginal delivery up to 48 hours. So either cesarean section or up to 48 hours of vaginal delivery. Much more easy and convenient and practically more possible at cesarean section. Now, there is a higher expulsion rate, but women, by definition, are better protected 6 months later. So though some of these devices can get expelled, actually comparing a woman who wanting effective contraception 6 months after birth, if you've offered her this post-placental, she is likely to be more protected than someone who has had been given like an interim appointment for an IUD fitting. There is no difference in other events. Mirena may have a slightly higher expulsion rate. And as we said, the implant is another important option. Abortion services, as I've mentioned, have been transformed in the pandemic era with a shift to medical abortions. In the UK, an emergency change in the law has allowed abortion at home, and this is likely to become permanent. Abortion at home is safe, is effective, and is actually preferred by the woman. It is much more empowering to the woman, and it saves the resources as the resources are becoming scarce within this time. We accept self-referrals, and as I say, the law allows home administration of both the mifepristone and the misoprostols. Women are relieved and feel in total control. We have extended in the UK the upper gestation to 10 weeks. It's been extended to 10 weeks in Finland, to 12 weeks in Scotland, and in the UK, we are probably going to follow that, 9 weeks in France. But the pandemic also has introduced some restrictive regimens, and some official bodies have used the pandemic to limit access. You can have remote follow-up, and ultrasound is only used if you are not sure of the dates, or if there is suspicion of ectopic. So the essentially the timing of the pregnancy, the dating of the pregnancy is done through history taking and the last menstrual period. And this is just published. A telemedicine abortion, this is from Scotland, published in the faculty journal, which is the BMA Sexual Reproductive Health. This is the reference. This is a survey of 665 women who had medical abortion at home. 98.2% were treated under 10 weeks. 78.7%, the gestation was determined from the last menstrual period. So nearly 4 in 5. 98% had a complete abortion. Under 1% had ongoing pregnancy. 0.6 had incomplete abortion, and only 2 out of the 665, 0.3 had a hemorrhage, and only 8.4 required a clinical visit. So be reassured that this is now the norm. This is now possible. This is now what is going to carry on happening. And the last bit of my talk in the last 3-4 minutes is love in the time of COVID. So they say there is now a new language, the new terminology. So you talk about lock blocking, which is having planned a date, and then you can't see your date because you have to self-isolate. So the solution is meet on Zoom and order a takeout, and you can have a meal on Zoom. Flumerang is another term, which is an old flame, someone you knew in the past, getting in touch because they are bored in lockdown. We say be kind, but do not commit. Sex bubble, this is a support bubble, but slightly sexier. And we say, don't go there, do not break the law. Date piling. So this is something that you can tell your patients that give them hope. Date piling is like a dating version of stockpiling. So you line up your dates, and when it's all over, it will happen. You will meet all of them, which means that we in the contraceptive services have to prepare ourselves for post-lockdown. Safe sex in COVID times, well, you need to be comfortable as a physician to talk about it, to talk about sex. If you know you are relaxed, they can share their intimate thoughts. Do not judge the patients. You need to talk about positions, alternatives to penetrative sex. Wearing a mask could be fun. You can at least wear a mask during orgasm where there is possibly some aerosol generating activity. If a woman is ill, no sex, but there are other ways of giving empathy and pleasure. And for lonely adults, there is Zoom dating, there's telephone sex. Always use contraception and always beware of intimate partner violence. You have to look after yourself and look after your staff. These are 2 of my nurses. They're smoking chocolate cigars just for fun, just to give us a relief from the emergencies that we've been dealing with. And as you know, telephone consultations, video consultations are now the norm. I wanted to share something that was published in from the US, looking at the use of telehealth. And you can see that the use of telehealth was 29% pre the pandemic. It's now 51%, nearly doubled during the pandemic. Digital SRH makes sense because the woman doesn't need to travel, doesn't need to take time off, doesn't need to worry about privacy and confidentiality, and it actually saves money and therefore ameliorates poverty. And it allows contraception really quickly, because if she gets in touch with you by phone and you can send her something to collect, then that would be good. It's good for rural communities, Canada, Australia, Scotland. It's good for ethnic marginalized populations who are worried to be seen in a family planning clinic, but you sometimes may need to pay for these services. I'm going to speed it up because we've got to have question time. And just to make sure that we understand that eHealth uses online platforms, mHealth uses mobile services. And I think this is really important because they are widely used in low-income settings, but they need local advocates, and as I say, they need codes for intimate partner violence. Pharmacies play a very, very, very important role in providing services. And we have just had Valentine's Day, so this is what we call the love bag for the COVID era. So if you want to prepare something you send to people, you need a condom, possibly a chlamydia test that they can return, emergency conception pill, a pregnancy testing kit, a progestin-only pill for bridging, lots of information and link to videos, something free, you can perfume samples, and a COVID gift would be a mask and a sanitizer. This is a study, again, from King's, from our service, looking at the uptake of online services. This is the SH24. I'm not going to spend time on it. It shows that there is good uptake from young people and good uptake from ethnic minorities. And I'm going to really end with thinking about not forgetting certain things. So don't forget services for young people, for working mothers, for mental health. And this I share with you again, it's from the Time survey, which was published this week. Have you ever received mental health care from a professional? Pre-COVID, 30%. During COVID, 24%. So you can see there is this reduction in access to mental health services. Relationship counseling, make sure that we use PPE, and don't forget everything else. You know, if we're thinking about COVID vaccines, you also make sure that your children are immunized. So thank you for listening, and together anything is possible. We need to keep the family happy, so you have the mother, the father, the baby, and the dog. And I wanted to just share with you, we are a sister society that we have the European Society virtual seminar, which is going to be on the 7th and the 8th of May. And you have the contact here, info@escrh.eu. And I'm going to leave this slide. This is our now postponed Congress. So we're going to hold our first face-to-face Congress in this beautiful city of Ghent in Belgium on the 25th to the 28th of May, 2022. Thank you very much for listening. And I'm sorry I've taken 2 minutes more than I should, but I'm happy to answer questions.
Thank you, Dr. Kubba, for such a wonderful presentation. And now for the Q&A session, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar control panel. All right, Dr. Kubba, it seems that we do not have any questions at the moment, but are there any final thoughts you'd like to leave us before ending today's webinar?
Well, I mean, I think one of the things that really have impressed me about the patients that I look after is that they have changed their behavior to a degree during the COVID era. And I think the points that I've made about self-management, about really finding strength in their own self and in their relationship to make sure that they keep well is very important. I think from the contraceptive point of view, as you've seen, the contraceptive services have actually adapted to the new COVID situation, and therefore we have the bridging concept of using the progestin-only pill, the extension of the license of long-acting reversible contraceptive, the fact that we can send supplies through pharmacies in the post or collected from clinics. Emergency conception has maintained its availability. And therefore, I think, we have very good solutions for contraceptive care. And I'm sure there are similar solutions for hormone therapy in the menopause. I can see that there is one question. I'm trying, so it says, if patients ask you about reliability of extended use, what do you tell them regarding efficacy of some LARC methods? Well, we definitely know, and I was the very early studies on Mirena, we definitely can say with real certainty that IUDs, copper IUDs, which are branded, i.e. they have the copper on the stem and the arms, are actually safe up to 12 years, maybe even longer. We can definitely say that Mirena is safe up to 6 years because it's already licensed in the US. The product Levocert is licensed in the US for that time. You have to remember that, for instance, the subdermal implant, in the studies that were done, actually there were no failures, which is amazing. So you think, well, why do we quote a failure of something like 0.1%? Because the people who were looking after the data said, well, if we go and say 0 failure rate, people won't believe it. So they've just put an arbitrary figure. So we think the implants also will last for definitely up to a year. So we can say it with certainty. Now, the woman decides. So if the woman says, well, okay, I will keep it, I'm not too worried about it, but I'm not too concerned about keeping it, but I'm worried about efficacy, you can always add a POP, a progesterone-only pill, to these methods, and that will be perfectly okay. So I hope that is a reasonable response. I'm quite happy if there are any other questions. We've got, I think, 2 minutes to go.
Yes, we have one more question. Do we still do PT before exchange, and why?
Do we do pregnancy testing? Is that the question?
Exactly.
Yeah. Right. Okay. Well, so we tend to, I mean, obviously I work both in private care and in the public sector. I think pregnancy, WHO says the pregnancies can be excluded by taking a good history, a good coital history. So if a woman says, I haven't had sex in the past 6 months, then she cannot be pregnant. By taking a good history about last menstrual period. If she's uncertain, then you need to do a pregnancy test. We don't do it routinely. I do it routinely in private practice because obviously we, in private practice, the hospitals we work in are worried about being sued by someone who may be pregnant. And I think if you are, you know, if you are busy and you do not have the time to scrutinize the menstrual history, apply the rules, then a pregnancy test is always an additional sort of reassurance that you're doing the right thing. So I wouldn't stand against it. It costs a bit, but you know, I think if that makes it safer for you to okay practice.
All right, Dr. Kubba, well, we do not have any more questions at the moment, so this will conclude the webinar. Again, thank you so much, Doctor, for your presentation.
Thank you. Thank you very much, Lina. And I'm quite happy. I gave my email in the first slide, so quite happy to answer questions by email. Thank you very much and have a good evening.
Thank you. Thank you to all the attendees for being here today and have a great rest of the day.
Thank you. Bye-bye.